Dear audience, dear Chairman, thank you for the friendly introduction. I think it's a little bit difficult now for me after these excellent talks to speak about dental MRI. I don't know who of you has experience with dental MRI, and it was for me a little bit a journey into something unknown when we started 2-3 years ago with my colleague to work on this issue. Now, the first thing we have to think about, is there any need for MRI in dental imaging? And I will focus on some points that perhaps might be interesting to think about. We'll shortly talk about technical requirements if we will perform dental MRI, and we will give you some information about first preclinical in vitro results and some clinical results regarding MRI in this environment. And then I will give you an outlook on what I think is very tremendous about really dedicated dental MRI imaging and high field MRI, and we can discuss this afterwards. The main pathologies that we deal with in dental imaging or dental pathologies in general are periodontitis. That is the most frequent inflammatory disease overall, and also caries is a very frequent disease, and this may lead, as we have seen before, also to periodontal or apical lesions that need the treatment of the dentist. So what is the normal approach to these pathologies? The normal approach is primarily clinical, and as we heard before, it's then X-ray and perhaps cone beam CT and multi-detector CT. The disadvantages of this routine dental imaging are that, as we saw before, that changes in pathology is only visible at an advanced stage when bony erosion has already occurred. So this might be rational to think about if we have an inflammatory disease of the gingiva that in a secondary step will also affect the bone, that we can get a more earlier diagnosis of the disease, if possible, with other techniques. The second question is perhaps that we see cystic or tumorous lesions that we cannot identify exactly with CT. We are based mainly on anatomic descriptions of these lesions. We try to get to the right answer, but there might be some help from MRI as well. So the last issue, even if this is not so important, perhaps, but it was stated before by my president colleague, Professor Galatner, that there is the amount of radiation doses, even with cone beam CT, is not so low. So even or especially in children, there might be some concern if we have to repeat X-ray examinations or even multi-detector CT or cone beam CT in these patients, and there are some hints that there might be an increase of risk of meningioma even with normal X-ray in children. So, what are the reasons? So we could think about dental MRI that potentially could give us a better contrast of the periodontal soft tissues, and therefore could give us an earlier diagnosis of inflammatory changes in this area, and perhaps it could help us to differentiate unclear lesions. That was the motivation to think about MRI for my group. On the other hand, MRI of the teeth and the jaw is technically and physically very difficult because we have a high amount of non-resonance material caused by the minerals in the teeth. About 50% in the dentine does not give any resonance or only very little resonance, and dental enamel, that's above the dentine, is even worse. It's 90% of minerals where we will not get easily a signal. And so what do we have to expect if we are trying to do MRI of the teeth and the adjacent structures? We have to work with very short or ultra-short echo times, and that may lead to the need of high-field MRI in these patients. We have to aim at highest resolution, and probably we need dedicated coils to get special information in this area. Now, I will give you some results, a report from some results we did on an experimental setting, an in vitro setting on MRI on the jaw of a pig. And you can see here we prepared this jaw even to take some measurements on the accuracy of MRI imaging. And this was a multifunction coil, an 8-canal multifunction coil from Noras that we could position from each side of the mandible to get the best signal possible. And we tried to compare the images of in vitro MRI on the jaw to multi-detector CT and cone beam CT. And what we found is quite interesting. These two images are MR images of the teeth and the root of the teeth. This is the section plane. So you can see here very nicely the pulp of the root, and you can see the dentine. And more surprisingly, you can see here this signal intense line of the periodontal space, and that's the space that is important for inflammatory changes in periodontitis. And so this structure is very, very easily to be seen with in vitro MRI. And adjacent there is the lamina dura, that is the practically cortical bone of the jaw, and this structure was seen even better than with a cone beam CT or with a multi-detector CT or cone beam CT. So as we analyzed these are the multi-planar reconstructions, and again you can see the pulp is easily displayed with MRI, and the foramen apices where you have the junction between the pulp and the periodontal space can be detected easily, and that's a very important anatomic structure. What is difficult to see is the differentiation between enamel and dentine. That is very easily seen, has been shown before on the cone beam CTs as well. In CT and cone beam CT imaging, we cannot, even if this is now a little bit truncated, we cannot differentiate easily these structures with MRI. These were the results on a visual scaling, and we found that these structures, periodontal space, lamina dura, cortical bone, trabecular bone, were significantly better to distinguish and to be seen with MRI than with CT techniques, as these structures, teeth, root, pulpa, dentine, were comparable on CT and cone beam CT. And the only structure that we could not differentiate or see better with MRI was the cement enamel junction, but this is another important structure. Now we tried to bring these results or this experience to a clinical routine or to a clinical question, and we performed a feasibility study on patients with periodontic and periapical lesions. And now we had to shift from a very special in vitro setting to a routine clinical setting on a 3 Tesla MRI with a normal head and neck coil. And we performed these sequences with high-resolution T2 and T1 sequences before and after contrast administration. And I must say this was a little bit disappointing. As we tried to see big structures, big lesions, and we could identify them, but imaging was much less detailed, much less precise as before. You can see here, this is a paraendo lesion on a molar 1.7, and we can see on MRI that there is some signal intensity on T2, and afterwards there is strong reaction on contrast gadolinium administration on subtraction images even more. But if you look on the teeth structure, the teeth themselves, they are not so nicely visible as in our in vitro experiment, of course. And then we try to see these changes on early suspicion in patients that had not so big changes on plain radiography. And again, we are able to see these changes here on periodontal space. There is some contrast agent, and again on multiplanar imaging, but it's not so impressive, I think. It's very difficult to see these changes, and you have to be used to look for these changes. So MR in a routine setting is very difficult to display these changes. It can display these changes, but it's difficult. Another patient with a periapical lesion, quite a big lesion, and what we found that is in this patient, we saw that the wall of this lesion was really thick, and there was a strong contrast enhancement. As in another patient, there was a very thin wall and there was nearly no contrast enhancement. So we tried to differentiate a little bit these lesions and correlate them with histology, and we were right that this was more likely to be infectious to inflammatory granuloma, and this was a cyst. This is another case of a patient where we try to monitor the treatment of inflammatory change on the periodontal region, and this is the control after 6 weeks and 12 weeks after treatment. We can see that the cyst is becoming smaller and the reaction are getting less. So this might be a possibility to monitor people, or especially children, with changes of the teeth under treatment. Now we tried to improve these our MRI setting with a dedicated 4-canal surface dental coil. This is not a military pilot, but this is the coil on the patient or the proband. And you can see this is not so easy to put into the face. We had to do some experiments that the patients can breathe easily, that they don't move so much. So it's not so easily done in MRI. And you can see that imaging becomes a little bit better. You can see now the pulp of the teeth and the spatial resolution is much better than with normal head and neck coil. And we tried to find out in this patient who had a tooth extraction of the wisdom molar that had afterwards some distortion of the perimental region, and we could see that there is some nerve affection, even if the nerve was not disrupted, but there was some actional injury afterwards. And we can see the signal intensity here nicely on MRI that could not be seen anyhow on cone beam CT. This is another patient with an ameloblastoma where it was difficult to consider if the mandibular nerve was affected or not. And we were able to see this with high-resolution MRI, that the nerve is displaced, but it is not infiltrated, and tumor could be removed easily without affecting the nerve. So this might be another indication for MRI for pre-surgical imaging. This is from another work published last year on 3D MRI imaging in children. And this is a patient who had these lesions or this tumor here that was not quite easy to identify. and they performed MRI, and they could see that there is some pulp inside these lesions. So these were additional tooth that could be removed afterwards. So that might be another indication for MRI in patients with unknown lesions. Now, taking a closer look to the teeth, and this is perhaps a future direction of dental MRI, but this is, as you can see here, only in an in vitro setting with 9.5 Tesla on a teeth. You can see now that it is possible to discriminate pulp, dentine, and even enamel with MRI, but with very short relaxations and echo times, as in this special SWIFT sequence. And here you can also see caries changes of the teeth. And these are perhaps future directions where we can look on. Another possibility are these ultra short and zero echo time sequences that give very close insight to the teeth. And you can see this is the normal structure of the teeth, that we can discriminate enamel, dentine, and pulp with MRI. And there is TE0. That means that we have no echo time, but this is a physical trick, and this is a very, very short pulse reading. These imaging takes a long time, so it's far away from routine imaging at the moment. This is another example for this technique, and this is a CT, and again you can see here the enamel is now visible with MRI, and you can see here carious lesions in the enamel part, and the dentine part of it that is now easily distinguishable. But well, on the other hand, you need 11 Tesla to perform this imaging. So I think I was a little bit too fast, but we can just come to the take-home message, if there is any take-home message for dental MRI. Well, it is technically feasible, but it's still experimental in my eyes. We need dedicated coils, and we need ultra-short or very short imaging in a high-field experimental setting. We can, or it's theoretically possible to get a very good and excellent depiction of teeth and also periodontal structures. But unresolved questions are the costs of this and, well, the technique. We cannot apply this at the moment on patients. If we are looking at routine MRI, it might be useful in the evaluation of inflammatory and cystic or tumor pathologies, and of the periodontal apical lesions, and especially in imaging of the nervus alveolaris before surgical treatment. It might be an alternative treatment modality, especially in children in non-erupted teeth or dislocated teeth, or even after trauma. Thank you very much.